Hello, and welcome to Mental Health Matters. I'm Edgar Wiggins, your host for this program that is dedicated to providing you with practical and useful information regarding mental health issues and needs. Untreated depression can be a debilitating illness that affects millions of Americans each year. Here to help us understand this significant concern is Dr. Annelle Primm, who is the Director of Minority and National Affairs for the American Psychiatric Association. Dr. Primm is a board-certified psychiatrist who's been practicing for over 25 years. Hello and welcome to Mental Health Matters, Dr. Primm.
Hello, Edgar. Thank you for having me.
First of all, so our viewers can understand the extent of this problem, when we talk about depression, exactly what are we talking about? I mean, we all have periods of just kind of not feeling ourselves and being down, but that's not what we're talking about when we're talking about clinical depression, are we?
Correct. Depression is a medical illness that affects how we think, it affects our mood, and even affects how we function. So it's a real illness and not just a passing matter.
Okay. When you talk about depression as an illness, can you give us a sense of how many people in this country it affects?
Somewhere between 15 and 19 million people will have some sort of depression. There are different types. There's major depression, there's dysthymic disorder, and other types of depression where people have symptoms but they're not as severe as the major types. But at any given point in time, close to 20 million people are suffering.
That's quite significant. Now, one of the things that we also are aware of is that when we think about mental illnesses and getting treatment for mental illnesses, the minority population in this country often lags behind in terms of seeking help.
That's correct, and we believe that one of the reasons for that is the great stigma that is associated with having a mental illness among people of color. As you know, in our society, people of color really bear the brunt of many burdens. They're often discriminated against and treated poorly. And so to take on another label of having a mental illness, even like depression, is something that you could understand that they might not want to do, to have sort of two strikes against them, if you will. Other issues that get in the way of people of color not seeking mental health services is very often they will seek alternative sources of help for problems like depression. They may go to the spiritual community to see their pastor or religious leader. They might go to their family or friends, often because of the lack of trust that they have in the health and the mental health system, given some of the historical realities of what life has been like for many members of these groups.
But if you're saying that, in fact, depression is a real medical illness, how is going to your pastor or family or friends for support, how is that going to impact this real medical illness?
Well, it really doesn't impact that real medical illness unless the people that you turn to are informed about it, which is why it's so important for us to mount public education efforts like this about depression so that people in society, pastors, other religious leaders, family, friends, co-workers, etc., can be aware of it. And so they can encourage people to go beyond sort of their natural supports around them to seeking some sort of health care, whether that be from a primary care physician, someone's family physician, or if they would consider it, seeking help from what we call the specialty mental health sector, psychiatrists, psychologists, and so forth.
Well, when we think about depression in this way, I mean, what would be some of the symptoms? What would be some of the warning signs? What would be some of the things that family members or friends or even somebody that's not feeling well, what might they look for?
Well, a person would look for sort of a list of 9 different symptoms and having, experiencing them most of the day, every day for a 2-week period or greater. Symptoms like sad mood or depressed mood, sometimes anxiety as well, or irritability, which sometimes is sort of a proxy for depression and sadness. In addition, loss of interest in activities, perhaps withdrawing from social contact, change in sleep or appetite, either up or down, and we know that people with depression may experience insomnia or they may oversleep quite a bit. They may have a reduced appetite and lose weight, or they may have an increased appetite and overeat. In addition, having lack of energy, having difficulty concentrating, having low self-esteem, and in fact to the point of feeling very guilty and blaming oneself for things, and having thoughts of death or suicide, which is one of the symptoms that can make depression a potentially lethal condition.
Well, the list of symptoms that you just listed, I mean, some of them are in fact paradoxical. You don't sleep enough, you sleep too much. You eat too much, you don't eat enough. You lose weight, you gain weight. I mean, it really seems to me that in terms of being able to come up with an accurate diagnosis so you can have the appropriate treatment, that you really do need a qualified healthcare professional to make that determination.
Well, you do, because this illness represents a change from the person's baseline or normal functioning. So in addition to having a healthcare professional who will try to get that information from the person, they also can benefit from having information from family members, coworkers, other people who know the individual well, who can tell you how they have changed, because it's not uncommon that a person with this illness doesn't really realize what's going on and may be in denial about it. So, having people who know the person is very important. And actually, there's some screening tools available now. For instance, the PHQ-9, or Patient Health Questionnaire, which is 9 items on it, very short, actually can give you a diagnosis. And the questions that are a part of this screening tool match almost exactly with the 9 symptoms that I talked about earlier. So there are ways that even a layperson, could give this screening tool to someone who they think might be depressed and score it and get a sense of whether that person has depression or not, and whether they need medical attention right away.
Well, let me ask you another question, because you talked about family and friends. Is depression an illness that runs in families?
Yes, it does. Like many illnesses, it's very common for relatives, biological relatives of the person, whether that be a sibling, a parent, grandparent, aunt, uncle, to have also had it. And if one of your relatives has had depression, it does not guarantee that you will experience it, but it certainly increases your risk and makes you more vulnerable. And we know that certain stressors in a person's life can bring out the depression, and doesn't necessarily cause it, but if a person is vulnerable due to family history, it can increase your risk.
So we are talking about an illness then that has a genetic predisposition.
Yes.
If a relative had it, there's a chance that under certain stressful circumstances, life stressful circumstances, that you may in fact have an episode of depression.
Yes.
But on the other hand, we're not talking about what we used to think or what people you see often in the movies and on TV, that something stressful or traumatic happened to someone and that's why they're depressed. It's not that kind of relationship.
For the most part, no, because if we think about it, everyone goes through stressful situations on a regular basis, and not everyone experiences depression. So there's something in individuals who have the illness that makes them more vulnerable than, the average person.
Now, my next question is whether or not, because I think this is also important, there is in fact something that happens to chemicals in the brain. There's some brain involvement, something called serotonin. Can you talk about that for just a minute?
Yes, there are a number of chemical messengers in the brain, some of which are responsible for helping to maintain normal mood. And some of them include serotonin, as you mentioned, norepinephrine, which used to be called adrenaline, which people are familiar with. That's another one that's been involved with mood. And also dopamine is another chemical messenger. And actually, these are the neurochemicals upon which many of the medication treatments are based, to make more of them available in the brain so that the person can have their normal mood restored.
So essentially then what the drugs do when they work is to help regulate these chemicals in the brain.
Yes.
Okay. So why is it then, if we have treatments that work and are available, that often minority individuals are not willing to come forward to avail themselves of these treatments?
Well, besides the stigma, also just the trust issue. Very often, people of color feel that they're not going to get a fair shake when they come in for treatment, that they're going to be mistreated. And there are a number of polls which actually bear that out, that they feel that they are talked down to in healthcare situations, and so it's not surprising that they would seek other means with individuals who they feel more comfortable with. Sometimes the communication from the physician or the healthcare provider leaves something to be desired. Maybe there's a lack of understanding about some of the cultural issues that may come into play with depression, some insensitivity there, or even some stereotypes and bias that come into play. So these are some of the things that we're beginning to understand, some of the differences in outcome that people of color experience when they do get treatment.
Okay.
And so there's still more work to be done to make sure that people of all backgrounds get high quality care when they finally do get in that door for treatment.
All right. And we're going to explore this further, but right now we have to take a break. We'll be right back.
I am a walking, talking miracle.
I am here because I survived leukemia.
Lymphoma, Hodgkin's disease, myeloma.
I'm here because of my strength,
my faith,
my treatments.
I'm here because of you.
Thanks to support for the Leukemia and Lymphoma Society, the survival rate for these cancers has nearly doubled in the last 40 years. Please help us keep the research going. Call 1-888-HELP-LLS.
I am a walking, talking miracle.
I am here because of you.
If all the drunk drivers arrested in Maryland during the past 3 years were here today, this stadium would be full. If you drink, drink responsibly. Remember, drunk driving, it's not worth the penalty.
Welcome back to Mental Health Matters. We're joined today by Dr. Annelle Primm, who is a board-certified practicing psychiatrist and the director of the Office of Minority and National Affairs for the American Psychiatric Association. Before the break, Dr. Primm, we were talking about the ways in which the illness of depression affects the minority population. And especially there's a concern about minority individuals not seeking help because of stigma and other reasons. But can you talk a little bit more about the way in which depression might manifest itself in minority populations, especially African Americans, Latinos, etc.?
Sure, I'd be happy to. Of course, members of the groups that you just mentioned experience depression in similar ways to the general population, but also may present in some different ways that people may not be familiar with. For instance, among Latinos, concerns about nerves or nervios or headaches, which, as you can imagine, could lead a physician down a very different pathway than depression. If they take that literally, they might think of an anxiety disorder, for instance, or some sort of problem, some sort of headache problem. Among Asians, weakness, tiredness, or imbalance might be the presenting complaint, which you might not necessarily think of depression with those kinds of symptoms. And in general, somatic or bodily complaints are very common among all of these groups. Among African Americans, concerns of being very irritable or evil, which is a cultural idiom that describes someone who is sort of crabby, difficult to get along with, and can easily be misunderstood as a person who's just a pain as opposed to someone who has a mental health need and depression. This is particular concern with men, African American men who are often misunderstood, and when they experience anger, people are afraid, and then they start thinking of them as a bad person instead of someone who needs our help and attention.
Well, one of the things that I've known to occur often is that men, African American, but other men, often their depression is communicated by irritability. And so often people completely miss the boat. And I remember a specific case where an individual was described as this kind of hardworking but very irritable individual who was hard to get along with. So people were in fact surprised when he killed himself. So in this case, as far as we can tell, the depression was really being communicated by his kind of irritability. And that's, I think, a concern especially for men. I guess one of the other questions, though, is how do we begin to decipher these complaints that are somatic complaints or complaints about things other than depression? How do we decipher them so that we understand that perhaps what we're really dealing with is a depressive illness?
Well, I think we need to be prepared to probe, to ask a number of questions. Don't just stop when the person says that they're angry. And in making a diagnosis of depression, it doesn't hinge on one symptom anyway. It's usually a number or a cluster of symptoms. Really, any disease is composed of a group of symptoms, not just one alone. So we would want to look at what company does the anger keep, if you will. Okay. If the person is also having difficulty sleeping or low energy, difficulty concentrating, low self-esteem, those might be clues that something else is going on, like depression. So we should never stop with just anger or any single symptom to hang our hat on a given diagnosis. We need to be thinking about, well, what else is going on? And of course, asking family and others to maybe get some more clues if the person themselves is not forthcoming.
Okay, so let's assume that we know that we have an individual that is experiencing clinical depression. What are the treatments? What can be done?
There are a number of treatments. Certainly medication is one type of treatment, and over the last 10, 15 years, there have been a number of developments making antidepressants much more available. There are several out there, so that if one doesn't work, perhaps another one will, and they're in different classes and categories, so you can go from one class to another if the first one doesn't work, and they have different side effect profiles. So that's really a blessing that we have so many choices now. In addition, psychotherapy or counseling is a very important part of treatment, and ideally should be combined with antidepressant treatment. But people can get better by having psychotherapy alone, which is really fascinating that just in speaking with someone in a confidential fashion, where they sort of help you understand the illness, perhaps help you see things in a much more positive light, can actually have an effect on the brain chemistry and structure, and it really does work. There are other treatments, electroconvulsive therapy or shock treatment, which, although people are sort of uncomfortable about it, generally it is very effective, especially for individuals who have severe depression and perhaps can't take medication, or perhaps the treating person does not want to wait for the medication to kick in, which usually takes 2 to 3 weeks to really start working.
But generally what I hear you saying is that if you were to put together an ideal treatment, it would probably be medication along with psychotherapy or talk therapy.
Yes.
Now, big issue, especially in minority populations. Folks don't want to take the medication. The things that I continue to hear are concerns that it's going to be habit-forming, addictive. Is that a real concern?
These medications are not addictive, but they should be supervised by a physician, and if a person decides that they don't want to take them anymore, they really should consult with a physician and not just stop them abruptly. But these medications are safe and effective. And of course, if somebody does not want medication, it's good to know that there is another treatment available that is also effective, and that is psychotherapy. And for those people who have what we call seasonal affective disorder or seasonal depression that tends to come with the fall and leave with the spring, there's certain types of light that are very effective in treating that. And so there are different things that we can do if people are adamant about not taking medication.
However, if you have diabetes, if you have hypertension, if you have some of the other illnesses that are very common in the minority population, you take medication, it helps control them. There doesn't seem to be the stigma that's associated with that. When we talk about antidepressant medication, then we have this concern. And one of my concerns is that individuals, in fact, are prolonging needless suffering because of what I believe are misconceptions about the medication.
That's true, and that's of great concern, because with most illnesses, the sooner that we intervene and deal with them, the better. The longer that we wait and let a lot of time elapse, the greater the risk is that the outcome is not going to be, the best. And we do know that among African Americans and other people of color, that depression tends to be more chronic and disabling. And some of that is attributed to the delays in seeking treatment.
But there also is the issue, is there not, of the relationship, let's say, between depression and diabetes, depression and hypertension,
Yes.
depression and, individuals that have had heart attacks, and
Absolutely.
there's some issues there in terms of recovery. So these are really important things, I think, for people to hear and understand. The other thing that I have to address, notice I have my own agenda, I'm not being shy about it, is the issue between the faith community, prayer, and mental illnesses. And can you just say a little bit about whether or not, I mean, I believe that prayer can be very, very helpful, but people that are depressed can continue to pray and take medication, can they not?
They can, and we really advocate for the two to go hand in hand. For people to keep their faith, to be prayerful. That is very helpful, and it's really an affirmation of their seeking of mental health. And so people should continue to engage in treatment for their mental health need, whether that be medication or psychotherapy, and continue to pray. And these are some of the things that we've been sharing with the religious community, because we in the mental health community see them as important partners and really as gatekeepers for individuals in their congregations who may need more help than they can provide.
That's very important. And what kind of work have you been doing with the faith community in terms of trying to get the message out?
Well, I've been working with Dr. Michael Torres and the Center for the Integration of Spirituality and Mental Health to educate people in the faith community, religious leaders, about what illnesses like depression are, what are some of the signs and symptoms, even how to screen for it, so that they are knowledgeable and equipped with tools for how to identify when someone that they're working with in their congregations may need help. And then, of course, making sure they know about resources for crisis services or counseling, psychiatrists and others who can provide additional care. And that's been a very successful endeavor.
Well, as always, seems like we're running out of time for this show, but I want to thank you for coming in to be with us today. I know you have a very busy schedule, you travel a lot, your time is sought after, and I just can't tell you how much I appreciate the work that you're doing across the country. Thank you for coming in.
Thank you.
And thank you, viewing audience, and remember, if you or someone you know needs help with a mental health problem or crisis, you can call Baltimore Crisis Response Incorporated 24 hours a day at 410-752-2272. And remember, your mental health matters to us.